I'm Dan Pollier from the University of Colorado, where I direct the Leukemia Service, and I'll be moderating today's tumor board. And I'm joined by some of my colleagues from around the country, and I'll let them introduce themselves, starting with Dr. Kamdar.
Hi, my name is Manali Kamdar. I'm an associate professor at the University of Colorado, and I lead the lymphoma program there. Glad to be here.
Hi, Tyler Fromm. I'm an assistant professor of radiology with appointments in both abdominal imaging and nuclear medicine at the Washington University School of Medicine in St. Louis, Missouri, and I'm happy to be here as well.
Hi, I'm Michael Thurman. I am an associate professor at the University of Chicago, section of hematology oncology. I focus on hematologic malignancies and in particular leukemias.
We're now going to talk about a DLBCL case. So this is a 58-year-old transplant ineligible female with a stage 4 T-cell rich B-cell lymphoma who initially presented with extranodal disease in the bone and FDG avid pleural effusions, completed first-line therapy with a PET CT at the end showing progressive lymphadenopathy and a large right femur mass impending fracture. So what would be our second-line salvage systemic therapy is the question. Another nice, easy, straightforward case. So initially this patient presents with a right lower extremity swelling and pain. Performance status is quite good at 0. The patient originally had menorrhagia. Social history is pertinent for the fact that this patient doesn't have insurance in our country, which is a challenge to provide medical care. Family history was non-contributory. So in August 2020, MRI shows this large pelvic mass, inguinal lymphadenopathy, compression of the iliac vein. And then in October 2020, a core biopsy of the right pelvic mass shows a large B-cell lymphoma. It's variably expressing CD30, which is rich in T-cells and histiocyte. And so, Manali, or Dr. Kamdar, let me stop right here. How rare is a diagnosis such as this, and how difficult is it to make?
So T-cell rich B-cell lymphoma is a very rare entity, a subtype of DLBCL. It unfortunately is not representative in a lot of clinical trials. Thus, what we do for it is primarily extrapolation from DLBCL NOS and the outcomes there. Historically, T-cell rich B-cell lymphoma, although belongs to the DLBCL category, if you look at the genomic and the molecular profiling, it actually is very reminiscent of nodular lymphocytic Hodgkin lymphoma. So there is actually very limited amount of malignant cell that you see, but it's surrounded by diffuse inflammation with T cells and histiocytes, and that's why the name. I think previously the standard of care has always been what we do for DLBCL, which is 6 cycles of R-CHOP. But there is now data that is coming out of single center studies, which have shown that regimen intensity is probably going to get the outcomes of T-cell rich B-cell lymphoma to where DLBCL is. And some of the high intensity regimens that have shown promise is our EPOC, dose-adjusted R-EPOC, or R-CHOP alternating with rice. So if this was my patient, I think the first thing that we would have done at our center would be 6 cycles of dose-adjusted EPOC-R. T-cell rich B-cell lymphoma has shown to have a higher predilection for the CNS. Although it's not part of the CNS IPI, there are certain centers that would also propose adding CNS prophylaxis. And I think we are one of those, so we would also recommend this. About 30 to 40% of patients will not really respond to therapy. And this is probably what may eventually happen with this woman as we look at the second line option.
Yeah, thank you. So yeah, in fact, this patient did get essentially R-CHOP with some CNS treatment. And then at the conclusion of this, here's what we see. And Dr. Fromm, maybe you can take us through her end of treatment PET
Sure. I also did want to make one comment on the, I guess what was presumably the initial staging PET-CT is referenced in the history provided and the sort of notion of FDG avid pleural effusions. So, FDG is just a glucose analog and will, accumulate anywhere that, a non-radiolabeled glucose molecule would. And, pleural effusions of sort of benign and malignant etiologies can accumulate FDG. So simply seeing some tracer signal within a pleural effusion doesn't really tell you that effusion is benign or malignant. What's really kind of helpful is if you can see a focal pleural-based lesion that is taking up the radio traces. So just one sort of comment about that initial treatment or sort of initial staging PET-CT. But sort of going on to this end of treatment PET-CT, what we do see, we have sort of multiple transaxial fused PET-CT images. On the left side, on the top, we see several FDG avid right pelvic sidewall lymph nodes, and on the image below that, on the left, we see a sort of more mildly or moderately avid left inguinal lymph node. And then on the right side, a pretty markedly avid sort of osseous lesion in the proximal right femur. And I'm kind of jumping ahead a slide here, but I think this slide kind of helps to drive home one of the points that we were discussing earlier, how the PET can be just really helpful in guiding sampling. So I believe this patient had excisional biopsy of that left inguinal lymph node, which had an SCV max of only 7.9, and that came back benign. You can see here that the pelvic sidewall lymph nodes, and especially the osseous lesion, are substantially more avid, and those would be sites that I think would be higher yield for biopsy, as I believe was the case here. Not to sort of get ahead of ourselves here, but just one of the takeaways from the images provided.
That's great. And yeah, I mean, I think that's, you're right on. That's exactly what happened. That left inguinal lymph node was more accessible, but less avid. And in fact, it was a benign lymph node. And so a repeat biopsy was done of the right femoral mass. And this one, in fact, shows a large B cells and reactive T cells with histiocytes concerning for persistence of the disease. So Dr. Camber, maybe you could tell us, what is the ideal management for patients such as this? And then, our patient that may not have access to our insurance system in the same way that an insured patient would, is there anything you could advise, that could help a patient with that?
I think the standard of care for patients with primary refractory aggressive B-cell lymphoma would be to do salvage chemotherapy so with RICE or RDHAP or R-GemOx, hoping for chemosensitivity, with the idea that if they were to be chemosensitive, to take them to a consolidative autotransplant. However, based on multiple analyses that have been done, for example, the SCHOLAR-1 data that actually shows that patients with primary refractory disease don't really enjoy overall survivals even more than 6 months. So at this point in time, I think it would be really helpful to enroll someone like this on a clinical trial. If clinical trials is not an option, then in that case, for primary refractory disease, I think some of the key clinical trials that have come up in DLBCL that will be presented at ASH would be a trial that looks at standard of care versus CAR T-cell therapy in DLBCL. And at least based on the press release, looks like CAR T-cell therapy showed a statistically significant EFS as compared to SOC. However, there was also a case report that came out of a single center of 9 cases with T-cell rich B-cell lymphoma, which were challenged with CAR T-cell therapy. And interestingly, all those 9 patients progressed at day 90. So I'm not quite certain if CAR T-cell therapy is the way to go for this patient. Nonetheless, I think there is a lot of I think we are marred here by the fact that the patient does not have insurance. So in an undocumented, uninsured patient, I think I would just get going with salvage therapy, such as RICE or RDHAP, and then hoping that she gets some sort of insurance, hoping that she demonstrates chemosensitivity. And if she does, then try to get her to an auto. And if she doesn't, then I think extrapolating some other regimens that are now currently approved for refractory DLBCL. Again, not a lot of data, but polatuzumab, bendamustine, rituximab, or tafasitamab, lenalidomide. These are some of the things that come to mind right now.
Great. So once again, a very challenging case. Just to summarize, primary refractory DLBCL, one can consider a more intensive chemotherapy salvage regimen, followed by autologous stem cell transplant. And although it's not a certainty that that's the best strategy, that's certainly a way to go. As we've heard so many times throughout this discussion today, clinical trial is always preferred, and I think certainly care at a specialized center would be of utmost importance for something this challenging.